Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry and promotes the highest standards of patient care with today's top experts in the field. Now here's your host, Dr. Joel Berg.
Thank you for tuning in to Pedo Teeth Talk, where we bring you the contemporary issues important to you and your practice. Brought to you by the American Academy of Pediatric Dentistry. Thank you to our Pedo Teeth Talk sponsor, Restorative Group, for helping us bring you great content. We couldn't do this without them. Visit them at www.hufriedy.com/AAPDcrowns. That's HUFREDY.group.com/AAPDcrowns. We are here today with Dr. Margherita Fontana. Dr. Fontana is the Clifford Nelson Endowed Professor of Dentistry in the Department of Cariology, Restorative Sciences and Endodontics at the University of Michigan School of Dentistry. She is Director of the Global Initiatives Program in Oral and Craniofacial Health at the School of Dentistry. She is currently co-director of Cariology courses and Cariology discipline co-coordinator at University of Michigan. As a principal investigator, she has received research grants from NIH, CMS, foundations, and the dental industry. She was the 2007-2008 president of the Cariology Group of the International Association for Dental Research, the 2010-2011 chair of the Cariology Section of the American Dental Education Association, and the 2016-2020 president of the American Academy of Cariology. She is currently the 2021-23 vice president of the European Organization for Caries Research, ORCA, and has been co-chair of the Alliance for Cavity-Free Future in Canada-U.S. chapter since 2015. Dr. Fontana, thanks so much for being with us on Pedo Teeth Talk.
Thank you, Dr. Berg. It's a pleasure to be here with you.
Well, I was so excited that you agreed to talk with me today, and we are sitting here today in April, about a month and a half before the annual session of APD, and you're going to be speaking there. We'll talk about that in a minute. Very excited about it, and I've wanted to get you on the podcast for a long time because you're our mentor when it comes to all things cariology, and I see many podcasts coming on this subject, but we'll cover a few important points today. So cariology, really, you could almost say that's dentistry, you know? I mean, most of what we do as dentists is treating the results of dental caries. We don't really manage the disease dental caries very much. Some of that is not our fault, a lot of it, because we haven't had the technology to see it or to manage it as a disease. And over time, not just today, I want to talk to you about all that, but you like to talk about cariology as being an evidence-based discipline, maybe more so than other aspects of dentistry. What's the philosophy and strategy around evidence-based cariology?
Yeah, so thank you. First of all, I'm very humbled by your introduction and to be in this podcast, and of course to attend the AAPD meeting. I am a big fan. I'm not a pediatric dentist, but I love working with children, and I really have great respect and admiration for all the work that pediatric dentists do. So as you mentioned before, cariology is really part of dentistry, right? The dental caries is one of the most common diseases we have to manage for our patients and communities. And so every dentist is really, or should be, an expert in cariology. But if you look at dental education, not only in the United States, but worldwide, the reality is that a lot of the emphasis, both in our accreditation standards until recently, as well as in our practice, how we get reimbursed, really is to manage the consequences of the disease. In fact, you see traditionally in accreditation standards, whether our students are good at restoring teeth using all the different technologies and materials that we have, et cetera. And some general standards about prevention, of course, and disease management, but really not an emphasis on understanding that dental caries is a chronic disease for many of our patients. And as any other chronic disease, if you think about if you're a diabetic or if you have any other chronic condition, this requires continuous management. You have to be involved as a patient. Of course, there's much more than you do at home that we can do for you in the office, but it requires a team approach with your healthcare professionals. professional. So the emphasis on talking about cariology separately than just general dentistry is to put the focus on the aspect of disease management that the dental caries process brings beyond just restoration of teeth, which is very, very important. And like anything else nowadays, really the push towards evidence-based dentistry, making sure that we offer to our patients the strategies that we know work and have a good potential to work when we use them on them.
Well, I think, I like to think as a pediatric dentist, and we're grateful, we want to stay closely connected to your work. It's the basis of what we do in practice. We're kind of clinical cariologists. Yet,
I love it.
Right. That's what pediatric dentists are. But we miss out on the part that you're talking about, which is the exciting future of disease management. And you make the comparison to diabetes, where most of diabetic care is disease management. It's not treating the outcomes. Hopefully you don't have those outcomes. In dentistry, it's all about those outcomes, as if we have no control. When we think about caries management and think about populations with caries, we often in pediatric dentistry kind of connect it with underrepresented communities because of the disparities in access to care, but the disease patterns are also greater. Can you say a little bit about some of the latest related to reduction in disparities and how that would impact the caries rates across the country?
Yeah, that is an excellent question, because I think, well, particularly since the pandemic, I think a lot of us who are involved with seeing patients at a private practice level or a community level have seen certainly what appears to be increases in disease presentation, either because people were not going for care, were afraid to going for care, because practices have had to reduce how they offer sometimes care, initially because of the pandemic restrictions, now because sometimes personnel issues. So we'll see. I mean, the science will tell us whether some of these patterns that we're seeing are true or not. But what we do know from evidence, and fortunately we have had a report, there's an oral health report in America that was published recently, that was a follow-up to the oral surgeon's report more than 2 decades ago, showing that certainly we have made a lot of gains, fortunately, in this country in many population groups where the experiences of dental caries, when you look at a population level, have improved for many groups. And yet, when you really dissect the groups by different population subgroups, we still see that not everyone has benefited the same from the wonderful strategies that we have. There's still a lot of disparities, not only in disease presentation and severity, but in access to care, to the treatments that we have available that we know work well. In fact, in many cases, the treatments that we have that work well are not accessible very well to those who need it the most. And so that helps to extend and amplify some of these disparities. And you all see it in your offices every day when you see patients coming with extending from severe ECC early in childhood to adolescence with complicated disease patterns and problems. So we still have a ways to go, even though we do know how to prevent and manage this disease. But it's a difficult disease to manage because a lot depends not on what we can do during our encounters, but what the patients have to do during their daily life and their daily behaviors.
And that's what I notice when I'm studying, like, as you describe, chronic disease management. In the case of diabetes being a good example, most of the health improvement is related to home care, what they do at home, whereas the dental industry is kind of promoted, come see me twice a year, let me clean your teeth. Oh, you have a couple fillings, I'll take care of it. It kind of reduces the responsibility in a way, or the opportunity for home care to be part of the solution. Speaking of managing disease, however, silver diamine fluoride entered the picture several years ago, and it's a game changer. It's the talk of the town, and I think we all know what we're talking about. But I want to focus in on a big clinical study that you're the principal investigator for, and I think this is what you're going to talk about at the annual session, where you have 3 sites, and you're the lead. Tell us a little bit about that study and what you're seeing so far, and what the meaning is of it, to the extent you can talk about it already.
Oh, I will. And I should say thank you to the AAPD for giving me or giving us, our team, some space to talk about this during the meeting. And please come and hear about our interim findings. But what I can tell you, so the reason we engage in this study, you might wonder, why did they do a study to show whether SDF is effective or not? Of course, we have numerous very good trials worldwide showing that SDF is an effective strategy for arresting caries lesions. But you might also be aware that SDF, the same as many of the topical fluoride treatments that we use in office, like fluoride varnishes, came into the US market kind of through a back door from the FDA as a class 2 medical device against sensitivity. This is perfectly okay, but that means that when you're using it for caries, whether it's arrest or prevention, you are using them off-label, which is still okay based on the evidence. Part of the problem, though, is that, and by the way, the only dental caries is a disease, and therefore in the United States, the FDA requires that if you want to make a claim against a disease, clinical trials have to be done in U.S. populations, because we have learned with many other conditions that different populations react different to different medications. And therefore, you want to really have trials on the populations that you're going to be using them. And so the FDA requires trials done in the United States. And when SDF came into the market, we really believed that, other than having fluoride toothpaste approved by the FDA, of course, for use for caries, this is an important enough strategy that it should be really labeled by the FDA as a medication that is effective and safe for use for dental caries. Not only that would facilitate perhaps dissemination and implementation, although COVID has helped a lot with that, I have to say, since we early on recognized that having something that was not aerosol producing might be even very advantageous to have, right? But additionally, because as products change, etc., you as the user, the dentist, you as the patient, the person who is receiving this strategy, want to make sure that there's data to support that treatment, however it gets modified over time, is effective for its intended use. And SDF, its initial intended use, as you know, was not like varnishes where you are putting them on sound teeth or non-cavitated lesions, where you could argue, well, even if we had a product that, let's say, a particular brand was not as effective as another, you have time to react and catch that before the problem becomes irreversible. In the case of SDF, it's very different because the initial application is for cavitated lesions, big holes on teeth that are active, and therefore they are progressing, and we want to act. And if we are wrong and this doesn't work, the consequences are going to be not very positive for the tooth and the patient in the short term rather than the long term. So having this approved by the FDA would not only be really groundbreaking in the United States, because since we've had fluoride toothpaste, we really have not had anything else approved for caries, with the evidence and the data and the support that products are effective, but it would also open the opportunity for many who might be perhaps more hesitant to use something off-label use than others, and therefore will expand the reach. So that was
that's a great teaser. I'm going to tell people we have everybody has to go to Dr. Fontana's lecture. It's going to be
oh my gosh.
This will help, and I'm excited about it. We will now pause for a word from our sponsor. Ufridi Group provides world-class products, services, and education, resulting in superior clinician outcomes. For more information, please visit www.ufridigroup.com/AAPD crowns. We are back with Dr. Margherita Fontana. Boy, I'm having fun talking about cariology. I think we're all clinical cariologists, and you've agreed to come back on the podcast many times. I hope, because you're going to be our mentor on the science part of cariology that we apply in practice. So to shift to the other extreme, we were talking about SDF, and we'll talk more about that. We'll hear your lecture. But let's shift to sealants, which really are on the prevention side, unlike SDF, as you indicated. Currently, it's mainly used with cavitated lesions. So what's the latest on sealants for prevention and arrest of caries lesions?
Yeah, I'm so glad that we're talking about sealants, because sealants are one of those strategies that we've been fortunate enough that we've had for a very long time, as long as we've had materials that can bond to the tooth structure, and we've developed into wonderful restorative materials, right? And we do have consistent data, regardless of who places them, as long as they're placed correctly, where they're done, which part of the world, etc., that these materials are very, very effective, not only to prevent caries lesions on surfaces or individuals that might be at risk, but also to arrest non-cavitated lesions on those surfaces. So both for primary and permanent teeth, covering those non-cavitated lesions that are active, of course, will arrest them better than many other alternatives. So sealants are a fantastic strategy. We've had them for a long time. The national data shows that their use is increasing, fortunately, because there was a time there for a while that it seemed like they were very underutilized. They're still underutilized, but we're seeing increases over time, which gives us hope. But there's still disparities in their use. A lot of the populations that really need them are still getting them less frequently than other groups of the population. So I think we all have to work together to really recognize this is a very effective strategy, and to support its use not only in our practices, but in the community-based programs. If you have in your community school-based programs or other community programs that provide sealants, help provide the support that they need.
That's great. Each of these is a big topic that we'll follow up on. They're all such important things. I want to talk briefly about a couple more things today in our limited time, and one is risk assessment. When you're talking about chronic disease management, in the case of diabetes, we keep using that example. It's a good example. There's a metric, your A1C, your blood sugar level, fasting glucose level. You have metrics that you can target and you can improve upon at home. Are we getting to some kind of risk assessment like that the consumer can think about, and not just tests in the office?
Yeah, this is also a very important topic, because we know inherently, and particularly any dentist who has any level of experience, it's very good at reading either the clinical data that they're looking at combined with the patient data to get that subjective impression of risk. This child is likely to continue to have caries lesions in the future if things don't change, or things are going to progressively get worse, or things might be getting better, right? But subjective assessments are variable. They're not very helpful, as you say, as objective metrics that we can use to really provide benchmarks for improvement, et cetera. So the science of risk assessment so far, for the most part, has been expert opinion based. And by that, I don't mean that we don't have evidence that, of course, consuming sugar is going to lead to more caries, or that having a lot of plaque stagnant on your teeth is going to lead with other conditions to likely develop caries lesions. Of course, we do know about individual risk factors. But when you put them all together, and when you're trying to find that spot where you can, with some level of accuracy, predict who is going to get worse and at what magnitude they're going to get worse, that's where a lot of the science is still lacking. We have put together this wonderful risk forms that I'm hoping many of your audience members use. They're good ways to make sure that we standardize what we're asking and how we're asking them. But for the most part, those forms serve two purposes. One, if the patient has disease, to make sure that you remember that they're likely to continue to have disease unless something changes. So that's still, unfortunately, the best predictor. And then to identify, hopefully, what are modifiable risk factors that we can work with that individual to try to alter over time towards a health state, right? But it's still a pretty subjective, lengthy, time-consuming process. So I think this whole science of risk assessment is moving towards having simplified and accurate forms, try to separate that disease management piece from the prediction piece, the prognostic piece. They're really two separate things that we kind of mix together, and trying to find ways of predicting not only who will have caries, but I would argue where they might have lesions, and at the speed and the rate of progression of those lesions. Because imagine that you could predict the kid that is going to have occlusal only lesions. You could say, well, this kid really would benefit from sealants versus the kid that is getting lesions mostly interproximal. And you might think, well, for that kid, sealants perhaps would not be as helpful as another strategy, for example, another fluoride-based strategy. So right now we throw everything on everyone since we can't be very precise on knowing what might work best. But I think hopefully the future will help us be more precise so that we can target interventions to those who need it the best.
That's a wonderful characterization you just gave, I have to say, of the state of risk assessment. Thank you. That was very helpful. We're going to follow up on a lot of that in the future, too. So last question, just briefly, you referred to Kerrys Detection as opposed to risk assessment, detecting lesions. You know, the Diagnodent came out a few years ago. Everybody bought one. Now it's on the shelf gathering dust because not because it was a bad product, but because it was highly sensitive but not specific. Can you comment on Kerrys Detection and diagnosis and where we are with that?
Yes, there's so many topics, right? This is so interesting. And they're all related to each other because the reality is you were talking about that metric. Well, one of the metrics that we have to know whether things are getting better or not is actually measuring what is happening at the tooth level. So do we have a caries lesion or not? How severe is it? And is it getting bigger or not? I have to say that if you are really careful with your caries detection using visual tactile methods and being careful not to cavitate things that are not cavitated yet, et cetera, and really looking beyond the cavitation state, really looking at those initial non-cavitated lesions, et cetera, you probably are not going to benefit from having a lot of other technologies. Where I think a lot of these technologies come into play, particularly if you are not very comfortable at measuring disease before the cavitation stage, there's no question that any of the multiple instruments that we have out there in practice can be very helpful to find some of those lesions. Now, they also find a lot of things that are not caries, which is why these are detection, not diagnostic instruments. They can help you find something, but at the end of the day, it's the same as when you look at a radiograph, right? You have to make, until we have a good AI algorithm, perhaps, you have to be the one to really decide whether what you're seeing is caries or not, and whether what you're seeing is likely active or not. So these instruments help. They do not replace you. And I think a lot of that actually could be done, perhaps also just having good intraoral or extraoral images of some of the lesions that you can help explain to your patients what is happening and why you want them to do, treatment A versus treatment B, et cetera. But there's no doubt that benchmarking the severity and the activity of that lesion is going to be the only way for you right now to monitor whether the treatment that you're doing is effective or not. Is the only way to tell whether the lesion is getting better or not, meaning it's not growing or might be reversing, depending on where you're looking at it, and whether things are progressing or not and how rapidly they are. So it is essential. It's the basis of everything else that we're going to do.
I think you've given me 20 different follow-up topics today. This was an amazing piece of information, all of this, and wow. Well, thank you, Dr. Fontana, for being with us today in Pedo Teeth Talk. I really appreciate it.
It was a pleasure. I look forward to talking about our SDF trial at the AAPD meeting. Thank you.
We're gonna be there.
Thank you. Bye-bye.
Do you need additional CE hours but don't have time to travel to courses? Did you attend annual session and want to listen to the audio recordings? Check out AAPD's new Education Passport. The redesigned and improved Education Passport is AAPD's online learning center, where you can earn CE and listen to audio recordings from all of our continuing education courses and more. Visit educationpassport.aapd.org for more information. For 10% off any product, use discount code TEETHTALK in the Education Passport store. Pedo Teeth Talk is the show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry. Be sure to check out previous episodes of Pedo Teeth Talk, as well as our other podcast platform, Newly Erupted. All previous episodes are available on our website. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.